where we sort of take off now. Okay. So first thing is understanding the basics. Do you understand murmurs?
Yes. With
Okay.
the thing with the mnemonic Mr. as Miss and Mrs. part.
Okay. I like that you have a mnemonic. I need your understanding to be A1. Okay. So here, right? Do you ever get these type of questions wrong?
I used to, but not anymore.
Okay. I'm just going to give you a couple of points. Okay.
Okay.
First thing is murmurs are always in the direction of flow. Okay. If the blood is going in certain direction, that's where the murmur is going to be. Okay. If it's going up because of aortic stenosis, that's where the murmur radiates to, right? If it's going down because of mitral stenosis, that's where the murmur will radiate to. It doesn't go any place else, right? The right ventricle pushes blood into the pulmonary artery. That's why the pulmonary area is over here, right? The right atrium presses the blood in this direction. That's why the area is over there, right? So murmur is always in the direction of flow. All murmurs increase in sound when increasing flow, because murmur is a part of turbulence. Whenever you have high, blood, more amount of blood, you can have more turbulence. Okay. The only exception to this, what is the two exceptions to this?
Welcome.
Hokum and starts with the M. Mitral valve prolapse.
MVP. Okay.
Right. So MVP and Hokum are the only ones that don't follow this rule. Okay. So these are the two rules that you have to remember. Okay. Now, as per the second rule, what did I say? It means whenever you increase the blood flow to the heart, your murmurs will increase in sound, right? So now we just have to remember what are all the different techniques that can increase blood flow to the heart, right? Do you know all the techniques?
That would be, or some would be Valsalva.
Okay, tell me what Valsalva does. Does it increase preload or decrease preload?
Valsalva is the one that you pinch your nose, right?
You can do that. Usually you pinch, like you close your mouth and you brace your stomach, right? Like flex your stomach. That's Valsalva.
So that would decrease.
Why would it decrease?
My logic is because you're basically, I think of the veins are constricting them.
That's it, right? Imagine. Have you ever seen like a weightlifter collapse because they lifted too much weight?
Yeah.
The reason why that is happening, they're under constant Valsalva. Their veins are pushed together like this, flat as a pancake, right? There's no blood flow going to the heart. Eventually, there's no blood flow going to the brain, right? So Valsalva, or pooping too hard, for too long, you're straining for too long, will cause you to have low preload to the heart. Next thing that it does is it increases afterload, right? Because it also pushes up against the aorta, right? So it's going to increase afterload, right? So we got one maneuver that decreases the preload, right? Now there's two phases of Valsalva. One is the straining phase where you put the pressure on, and second one is the release phase. That means you've let go of that pressure, right? So if they ever say Valsalva, ask them, and they're not clear, ask them what sort of phase are you talking about? Because generally it leads to low preload, but in the release phase, there's a rush of blood going back to the heart. Okay. So in release phase of Valsalva, preload will be high. Does that make sense? Okay. Next is I ask the patient to lay flat. I lift up their leg passively. All that blood will go back to their heart. Right. Or I tell the patient to raise their arms. All the blood from their arms will go into their heart. Okay. Those are all increasing preload. They will increase murmur. Okay. Next is,
what you're saying is that whenever you, what was I going to say? Whenever you increase preload, that's when you increase the sound of the murmurs.
Exactly. That's it. Except what? Except two?
Except Hokum and MVP.
That's it.
Oh.
Okay. Next, I'll give you a couple more. Next is hand grip. Okay. When you constrict your hand into a fist, all of these capillaries, they're constricted, right? All the arteries have this back pressure that goes back into the heart. Okay. So constricting your hands and making a fist causes afterload to increase. Does that make sense?
Yeah.
Okay. So if they ever say, what are the maneuvers that increase afterload? Hand grip, and then eventually Valsalva as well. Okay. Next comes squatting. Have you heard of when you squat, what happens to your veins?
They also constrict, so same thing.
So yeah, so the thing is, there's two things that happen. So veins, right? Because you're pushing your leg muscles against fascia, so veins will send blood back to the heart. Okay, but arteries will be constricted. Right? Imagine you have blood in your legs. As soon as you squat down, you see you're forcing the blood to escape up.
Oh, okay.
Right? It escapes up. Okay. But then the capillaries that are supplying those muscles, now they have a tougher time and they won't. Okay. So preload is increased with squatting. Okay, so everything that we talked about here basically leads to higher amount of preload. Wherever we see preload being high, right, it will lead to most murmurs becoming higher in volume, right? Except MVP and HOCM, as you said, right? Now the thing with afterload, okay, afterload. You see, when I go back to this diagram right here, I'll show you. There's something called, yes. So imagine aorta experiencing high pressure, right? Now, whenever you have high pressure, here is where the high pressure will be felt, right? Imagine you have high pressure here, okay? Let's say a person has aortic stenosis, right? If someone has aortic stenosis, what happens to their left ventricle pressure?
It's gonna increase.
Increase, exactly, right? It's very, very increased, right? So when blood from a high pressure scenario goes to a low pressure scenario, it produces the murmur, right?
Okay.
Right? So like forget about afterload for a second, right? Just remember high pressure scenario to a low pressure scenario, right? A lot of turbulence, a lot of sound, right? But if I increase the afterload, what will happen? Everything that you see here will start experiencing high amounts of pressure, right? So what's going to happen with these two pressures? They start to cancel each other out.
Okay.
Right? That's called the transaortic valvular gradient, pressure gradient. Okay. Once these two cancel out, you will not hear the murmur. You see, the difference is previously it was just high to low pressure, but now you have high pressure in both the situations. So if I minus them, it's just going to cancel out, right? So murmurs, for example, aortic stenosis, they actually decrease because of hand grip, anything that causes high afterload.
Okay.
Right? So always remember, whenever you have back pressure going back to the heart, and if someone has aortic stenosis, you hear that murmur decrease in quantity, in sound, you probably have aortic stenosis.
Okay.
Right? But then if I put high afterload in someone who has regurg, aortic regurg, of course it'll increase. Mitral regurg will increase, right? VSD will increase. This makes sense? These two scenarios make sense?
Yeah, yeah.
Okay, good. Lastly, you have to tell me, if someone is inspiring, right, what happens to their preload? Does it increase or does it decrease?
It would increase.
Preload would increase. Okay, why is that?
Because I guess you're giving more space to your heart to like refill.
Okay, yeah, I'll take that, right? The thing is, whenever the diaphragm goes down, you produce negative pressure in the thoracic cavity. That will suck the air in, right? It also sucks the blood from the IVC up. Does that make sense? So both, because of that negative pressure, both the air will come in and the blood will come in. So yes, preload will increase. Okay, but the preload is usually just part of right heart stuff. So whenever you talk about if they ever say that the murmur increased on inspiration, it's mostly the right-sided murmurs. For example, tricuspid regurg, right? Tricuspid stenosis, right? Or maybe like pulmonary artery stenosis, pulmonary artery regurg. Because what am I doing? The principle is if you put more blood in the system, it will increase in murmur intensity. That's all, right? The principle still remains. The left side won't sort of like experience that, but it will experience expiration pressures. Why? Because when you have expiration, you have to force your blood against high pressure, positive pressure, right? So left-sided murmurs, they actually decrease with expiration. Okay, so if someone has aortic stenosis, aortic regurg, again, the pressure will start to equalize, right? So that's why this is happening.
So left-sided murmurs, when they expire, they would decrease it.
They decrease, right? But right-sided murmurs increase with inspiration.
Okay. Okay.
Yeah. All right. Now, so what happens is when we understood how inspiration makes the changes, right? It increases the preload and stuff, right? The left heart has thick musculature. Right heart doesn't, right? So whenever you put more blood in, whenever you inspire, you put more blood in, the right heart takes a longer second to sort of contract and get all that blood out, right?
Okay.
So that's why you see whenever you inspire, you see aortic is just fine, but the pulmonary system, because of higher, longer duration of blood going out, and then the closure happens late, that's why it splits. Does that make sense?
Okay. Yeah.
So splitting is a normal phenomena, happens because inspiration causes high preload, venous return.
Okay.
Right? So when I hear this person's sound, even if they give me a sound clip, understand how it will sound, right? When the person inspires, you will see three sounds, like lub 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 lub. Why?
Okay.
Because that one sound is split into two, lub, right? But this one might sound lub dub, right? Clear lub dub. But this one has two beats on it, lub like that. Okay?
Okay.
And that's normal, right? Now, what ends up happening is, imagine there are pathologies that lead to the right ventricle even causing further delay in closure. of the valve, right? Because you understand S1 and S2 are because of closure of valves, right? They're not because of opening, they're because of closure, right? Now, wait, just to make sure you know, S1 is what closure of which valve? S1 is mitral and tricuspid closing together, but S2 is the one we're talking about here, aortic component and then the pulmonary component. Does that make sense?
Aortic component, pulmonary component. Yeah.
Of S2, just S2. This is all S2.
Yeah, A2 and P2 is S.
Okay, good. Now there's another simple question. How many leaflets do all the valves have typically? Every valve is supposed to be 3 except the bicuspid, which is mitral. Okay, just making sure you know that. Okay, all right. So where was I? So any pathology that leads to right ventricle having further delay, right, will lead to wide splitting. You see, typically it was supposed to be over here, right? And whenever you inspire, you see a longer delay. Okay, so we understand this. So for example, pulmonic stenosis, right bundle branch block, pulmonary artery hypertension, all of these are causing a further delay in right ventricular contraction or closure of the valve. Make sense? You see, if the valve is stenosed, will the blood go all the way out and close in time?
No.
Easily, exactly, right? With bundle branch block, you have ECG, conduction problem. It will not go out completely. Does that make sense?
Got
Right?
that.
Pulmonary artery hypertension. Again, you have hypertension, you have to push against so much pressure. You're not going to do that in time, right? It's going to take some while, right? So wide splitting, whenever they say wide splitting, remember what happened, right? There is some right ventricular delay, right ventricular pathology. Got it?
Yeah.
Okay. Next comes paradoxical splitting. Okay. Paradoxical splitting means left ventricular pathology, right? Aortic stenosis happened, you see aorta, the left bundle branch block happened, maybe left, hypertension or something like that. That is what is causing the left ventricular delay. Right? So how do you understand this when you just listen to someone? The thing is, whenever you tell this person to inspire, the two components, you won't know. You see, right now it's all labeled for you, right? Imagine you don't know what you're listening to, right? If you tell a person to inspire and the two components come closer together, that means this is a paradoxical splitting. What was happening in wide splitting? When you tell the person to inspire, it goes further apart, right? But here, the thing will get closer. That is yeah. Right? And the thing is, you understand, you see, aortic component, that's the problem. Pulmonary component is perfectly fine. This is normal. It's supposed to do what it's supposed to do. And you see, the splitting is actually making the volume closer to the aortic component. That's the only thing.
Okay.
Right? So the pulmonary system is doing just fine, but the aortic component is so far apart, it's taking so much time to contract that you may see a sound, which is the split is closer than the expiration. Right? Okay. So that is paradoxical splitting. Fixed splitting is very easy. People just remember it. It's ASD. Why? Because there's equal pressures between the ventricle, right ventricle, and the left ventricle. So both of them will obviously close in time. Does that make sense? So there's no splitting actually.
And that's pathological.
Yes, ASD.
You do have a splitting. Got it.
Okay. So we understand these three scenarios now?
Yeah.
Right? So don't get confused. Sometimes they will like to write it out in letters, right? Here's what they will say. On inspiration, the pulmonary and the aortic components of the S2 are coming closer together. That means this is paradoxical. Okay. On inspiration, the aortic and the pulmonary components move further apart, wide splitting.
Got it.
Okay, good. All right, so we understand that. Now you tell me what is S3 and S4. I'll make it easier for you to understand. Okay. Imagine you have a bucket, right, or even like a glass. It has fluid or some water already in it, right? You open up the tap and the water drips into it, right? If the glass or your bucket is already filled with water, right? Water hits water, it makes turbulence, right? That is S3. Okay. If there is higher filling pressures or if there's fluid already in the heart, then S3 will make a sound.
Okay.
S4 is, imagine you take the cup or the bucket and the water, instead of hitting the thing that was already in there, the blood that was, or the fluid that was in there, now it hits the wall and it bounces off the wall, right? That's going to be S4 sound. Does that make sense?
Yes.
Okay. So S3 is when it hits the water. S4 is when it hits the wall, right? If the wall is hard, it's going to make a lot of turbulence. It's going to make a lot of sound, right? That's why they say stiffened left ventricle. That's the important keyword, stiffened left ventricle, right? So restrictive cardiomyopathy, anything that leads to restrictive cardiomyopathy, anything that leads to the heart becoming stiffer.
Got it.
Anything that leads to hypertrophy, S4. Okay. Now, the main couple of important points, this is early, this is late. But all of them, S1, S2 is systole sounds, S3 and S4 is diastole sounds. Okay.
Okay.
So you tell me this. If I say lub dub, right? Will
Mhm.
S3 and S4 be in the lub dub, or will it be outside the lub dub?
Outside the lub dub.
Outside the lub dub. So this is the trick that comes to you when you want to hear something on this depth, right? If there is a sound that is within the lub dub, then it's a systolic sound.
Mm.
Okay. I need you to understand it and go on YouTube when you're done, right? If you hear lup dub, lup dub, lup dub, what is that? That's a systolic sound.
Okay.
You understand? Right?
Yeah.
But if you hear lub dub, lub dub, lub dub, what is that? Diastolic sound.
Oh, that makes sense.
Okay. So always hear for the lub dub. You can hear the splitting too, like lub 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 lub. But then the actual murmur should be classified first by listening. Is it between S1 and S2, or is it outside S1 and S2?
Okay.
Because it's very simple after that. If you can classify something as systolic murmur versus diastolic murmur, then I just have to know the location. Is it happening at the second intercostal space? Then it's aortic stenosis. Happening at the left lateral decubitus position going to the axilla or something, then it's mitral stenosis, right? If it's going to the pulmonic area, then it's maybe mitral regurg or tricuspid, pulmonary stenosis or whatever, right? So everything comes down to you listening to that lup lup dub or something. Okay.
Okay.
All right, good. Now, just so I understand that what are the systolic murmurs and the diastolic murmurs? There's total 4.
Systolic murmurs are mitral regurg and aortic stenosis.
Mhm.
Diastolic is mitral stenosis and aortic regurg.
Exactly. Good. Right. I need you to imagine it. I know you can come up with like a mnemonic for it, but imagine it. Okay. So systolic murmurs, they're both going upwards, right? And with the diastolic murmurs, they're both going downwards.
Oh, that's awesome.
Now, do we understand all of this?
Yeah.
Okay, good.
Well, yeah.
I need you to look over it. Okay. If there's some problem, you can ask me, right?
Yeah.
But understand each and every sort of phase. Okay.
Yeah, gotcha. Yeah.
Right. So first, I'm going to go over is this PV loop. Okay. Now, PV loop is important for heart failure purposes too. Okay. So I'm going to go into heart failure after this because we've done most of the work. I'm going to do PV loop introduction, and then I'm going to go into JV tracing. Okay. I'll show you. All right. So do we understand what does it mean by the width of this graph? What does this graph width mean? It says here, stroke volume.
Yeah. Uh-huh.
Right? This is how much blood is left in the heart after systole, after contraction, right? This is how much blood you gave after diastole. You subtracted 2, you get stroke volume.
Mhm.
Right? You start here. Every time you hear a PV loop, you start at the base over here. Okay? You go up, causing isovolumetric. You see, one volume goes up, and then it finally, once you reach that much pressure, then it goes and squirts the blood into the aorta, and then comes back and makes the S2, and then eventually goes down and makes the diastole begin. Okay, so understanding that is fine, right? The main thing that understanding this actually needs is you have to understand the different scenarios, right? Everything that we did so far with the preload, right? Everything that we did with the preload, is it passive leg raise? Is it inspiration? Anything, right? That will increase the end diastolic volume, increasing the stroke volume. Does that make sense? Now, what if there was increased afterload? So all the maneuvers that we did, right? The strain phase of Valsalva, squatting, right? Or hand grip, right? All of those are leading to high afterload, which means EDG, the diastolic will not change, but you have to generate high amounts of pressure. You see, more than 140 mMs to even reach, that much amount of flow, right? But the thing is, the flow is never going to be as great as if it was relaxed, right? So the end systolic volume will increase. Okay, end systolic volume has increased.
Mhm.
So the stroke volume, total, subtraction will decrease. Make
Done.
sense?
Yeah.
All right, good. So stroke volume decreases, but the pressure has increased in afterload, right? This is these two we've discussed, right?
Yeah.
What we haven't discussed is, let's say I give my patient beta 1 agonist drugs, right? Because beta 1 is what's located in the heart, right?
Mhm.
So do you remember any drugs that are beta 1 agonists? Secondly, dobutamine, isoproterenol, right? All of these are common drugs that you will see in the step, right? They're all leading to beta 1 agonism, leading to contractility, right? So if something leads to contractility of the heart, you see what's happening. Both of and I'll show you what this line means later, okay? But you understand, you see, you're pushing out more of the blood out of the heart, right? Which means the end systolic volume has decreased. It's come to a new low. This makes sense?
Yeah.
Okay, good. Now, what cardiologists saw was they came up with two lines. Okay, first line is the ESPVR. Okay, ESPVR means end systolic pressure volume relationship. Right, it's just a line that goes from the origin up to the closure of the S2, which is end of systole. Right, that's why end systolic. Right, end systolic pressure volume relationship. Right, and then they came up with a second line called end diastolic pressure volume relationship. Okay, this line.
Yeah.
Right. What they saw and what you need to understand is if you increase the contractility, I'm going to come back to this graph, right? If you increase the contractility, the slope of the graph increases. Okay. You see, it was previously here, right? Somewhere here. And then it has gone to this place. Right?
Okay.
So whenever you increase the contractility, the slope will increase. Okay.
Okay.
So this whole line just represents the essence of that line. ESPVR in your mind should be contractility of the heart.
Perfect.
Can you remember that?
Yeah.
Okay, good. Now, if there is heart failure, what's going to happen to the slope? You tell me.
It's gonna go low.
Go down, exactly, right? So it will go down, it will move right, right? So ESPVR will decrease or contractility will decrease. Make sense?
Yeah.
All right, good. Next comes EDPVR. EDPVR means compliance of the heart. Okay, EDPVR means compliance of the heart. If compliance is decreased, that means the ventricle is stiffened, right? So you have a stiffened ventricle, right? Or you have something already in the heart, which means there's already some amount of blood in there, right?
Okay.
Right? So whenever you have low compliance, this whole graph becomes like this, right? It increases. It actually goes up, okay? It goes up, right? So I'll show you these two graphs. Okay, you see how it's gone up?
When there's low compliance, you said.
Yes, when there's low compliance, it goes up like that.
Okay.
Right? When there's high compliance, it goes down, right? Now, understand why I said low compliance and then it's going up. Understand this, okay? So if I am at this position, let's compare these two positions right here, right? At this position, the volume remains the same. Let's say, I don't know, 100 mLs, right? At 100 ml, this is the pressure that this graph is experiencing. And then at 100 mLs, this is the pressure that this heart is experiencing. So you understand? Even at rest, even at some amount of place, this heart, right, is more stiff. It's experiencing high amounts of pressure on the walls, right? It's more stiff. That's why it's experiencing this high pressure, even at a given volume. Does that make sense? Okay. So as soon as you go up over here, it means compliance is decreasing. Okay. Now let's just discuss all the things. So restrictive cardiomyopathy here, right? Left ventricular hypertrophy here. As you see, diastolic heart failure. I'll explain this, but you already know it. You see, when diastolic heart failure, the heart is already filled with fluid. It can't, stretch any longer. You understand? It's already very stiff. That's why it's here.
Got it.
Okay. But then if it goes down, if compliance increases in what? Dilated cardiomyopathy. You understand?
Yeah, yeah.
So if you have dilated cardiomyopathy, that heart will become bigger and bigger and bigger. It may lead to the compliance increasing. And then the main thing that I was going to go for, heart failure, you see, contractility decreases, so you have a new slope over here. And if you have diastolic heart failure, you see, it's not receiving blood properly. It's being non-compliant. It will increase. So much fluid in it, it's non-compliant. You see how much water can you fill in a water balloon if it's already filled? Does that make sense? Right? It's already very, very non-compliant for you. It's stretched already. So any sort of heart failure undergoing heart will be non-compliant. Okay.
Yeah.
All right. Take a picture of this. Keep the screenshots with you. Okay. I need you to look over them. Keep them in a safe place. I hope whenever you take a screenshot, you're eventually looking over it. Okay.
I do. Yeah.
Okay. Good. All right. So we understand this. Let me zoom out a bit. These are on Wikipedia, but keep this. Take this one, and I'm just gonna explain this. Right. So you see, there's two types of graphs that you see here. One is acute heart failure. Right. In acute heart failure, what you see is there's no compliance changing. Right. You see, everything is within that same graph, but the overall contractility has decreased, right? But as soon as you see chronic heart failure, now you've allowed your the heart to expand, right? It becomes more dilated, right? So the compliance is actually decreased. You see, it's lower, right? It's becoming larger and larger, dilated, right? And then there's only a mild change in contractility, but the main change is in the compliance.
Okay.
Right? That's it. Okay. So that is PV loops. Okay. I am going to go back to heart failure, but after this. Okay. JV tracings and stuff. So far, all this discussion is tying everything together.
Yeah, it's crazy how I would understand it, and now I do.
Good. I've been JV pulse, right? Now JV pulse means right atrium pressure. Okay. right atrium pressure is determined by a lot of movement that is going on in the right atrium. For example, whenever the ventricles, have systole, the tricuspid kind of bulges up, right? The right atrium experiences that. If the right atrium is filled, it expands. The right atrium experiences that. So the why are we, doing all this is because I need to know that what is the resting sort of diastolic pressure of the heart. Okay, that is what the JVP sort of is going to help me with. Okay, now before we understand fully what JVP is, you have to understand the phases of the heart. Okay, now when I'm filling the ventricles, right? There's 2 to 3 phases, right? First phase is as soon as the valve opens, gravity, not the atria, right? Gravity allows blood to flow down. Okay, that is called rapid filling, right? So as soon as the thing opens, rush of blood, and that is called rapid filling, and that is about 70% of the blood.
Okay.
Okay. Now, next phase is called reduced filling. Even in this case, it's still gravity. It's just like a slow waterfall now, right? But in this case, about 25% of the blood is filled, right? Lastly, is the atrial systole. That's the actual contraction, but how much blood does it actually lead to? Maybe 5 to 10%, right? You have to understand, atrial systole is not the major contributing part, right? People think, what, if atria doesn't contract, ventricles don't get blood. No,
It's gravity.
right? It's gravity, and the fluid is in a contained space. If you open it, of course, fluid dynamics, it'll go down, right? It'll go to a lower pressure, easy. Okay, so understand that, right? So we led about we understand about the 3 phases: rapid filling, reduced filling, and the atrial systole. Okay, now we can look at the JVP pressure. So when the atrial contracts, of course, it's going to have the A wave, right? The A wave is the atrial contraction. Okay, because all of this is systole, right? So now you see, now comes the C wave, right? C wave is right ventricular contraction, which means the ventricles downstairs are undergoing high pressure, and that is felt in the right atrium. Okay, so A is for atrial kick, C is for contraction. Okay.
Okay.
X is now for atrial relaxation, right? Which means both the ventricles and the atria are relaxing, right? So both of them are experiencing less amount of flow, right? Less amount of pressure. So everything is going out if both of them are continuing to relax. Does that make sense? Right? So A wave, C wave, and X wave. And then once they're starting to relax, you see the right ventricle is filling up with blood. So it slowly goes up. It's slowly filling up with blood from IVC and SVC. So V is venous filling. That's how you remember it. V is for vein filling.
Okay.
Okay. Now, if that is filled, as soon as you open the atrial ventricular valve, then you see the pressure goes down again. Right. So Y wave is right atrium emptying. So let's put everything back together again. Okay. So let's start from here. Right. V is blood in the atria. Y is now the atrial blood is going into the ventricles. A is the kick, right? C is the ventricles contracting. X is the ventricles and the atria relaxing. Does that make sense?
You said A is what?
Atrial kick, atrial contraction.
Okay.
Right? So V is filling, Y is emptying, A is atrial kick, C is the contraction of the ventricles, right? And then X is relaxation of both of them. Right? Okay. It's important to know this because let's say if a person has atrial fibrillation. So what is the problem you're going to see? What is going to be the problem in this graph? This was the atrial contraction, right? Atrial systole. So AFib, no, there's not going to be any A wave. Okay, you come down here, you see, absent A wave. There's no A wave. Does this make sense?
Yeah. Because that right atrium is not contracting.
Exactly.
Okay.
Right. So if someone says upon looking at the JVP, the A waves were missing, this is atrial fibrillation.
Got it.
Okay. Now you look at tricuspid regurg. You see, they've given you, this wasn't there in the previous first aids, right? But they used to ask about it. So they made it all the way into the notes now, right? Now look at tricuspid regurg. In tricuspid regurg, you have, when you have ventricles contracting, you have you see the ventricles are sending the blood back into the atrium, right? So you see, this was C wave, right? C wave was when ventricles contract. But now the atrium is experiencing high pressure, you understand, during the C wave.
So that's why there's no relaxation.
Exactly. So there's no X descent, no relaxation. You understand that now? Good. Now we get into the confusing parts: constrictive pericarditis and cardiac tamponade. Okay. Now with constrictive pericarditis, you see they're not allowing the heart to relax or to contract properly, because you have this wall that is preventing movement, right? So what ends up happening is, you see, first of all, the entire C wave, right, the contraction wave, it can be lost, but you see the highs and the lows, they're very, very prominent. Okay, this, you see, filling at high pressure, relaxing at lower pressure, right? Because there's a stiff, covering that is, constricting the heart, right? So it's very, very hard for the heart to relax and even contract. That's why there's high amounts of pressure in either direction. Okay, see how shallow this is compared to like this. You see the Y wave?
Yeah.
Right, very, very deep Y wave. C wave can be sort of kind of be lost, right? Because you might not feel the contraction in the atrium.
Okay.
Right. So the main thing is prominent Y wave, right? And you remember the Y wave is the rapid filling stage, right? The right atrium is supposed to sort of go into, the blood is supposed to go down, right? So it's going at a very, very, high intense pressure. Okay. But then you look at cardiac tamponade. Cardiac tamponade means there's so much blood surrounding the ventricles that is not allowing any of them to sort of, move properly or fill properly. Okay. So now the Y wave is completely missing, right? Because you're not even allowing the heart to fill properly. Does that make sense?
Yeah. Yeah.
So even though the atrium might be, receiving the blood, it may not be able to fully send it out to the ventricles because there's so much fluid pushing it. Okay. So that's the two way. The Y is very high in this, and it's absent in the cardiac tamponade. That's the main thing. Now, sometimes you will see in some questions that they just give you the graph, right? And then you're concerned about which one is this, which versus which one is that. Has that happened to you? Have you seen these questions before?
The one in the graph on the left, I can technically kind of say, but the other one I would have issues. And
okay, let me just show you, right? We discussed afterload. You see high pressure, lower stroke volume, right? Then when you look at this graph, you have to understand which one's which. Okay, this one is your aortic pressure, the pink one. Okay, the blue one is your left ventricular pressure, and the green one is your atrium pressure. Okay, so the blue is going above the aortic, as it should, because it has to push against a stenotic valve.
So more pressure going in.
Exactly. Okay, so that's how you interpret this. Don't get confused. Okay, this is the blue. This one is the left ventricular pressure, because if they didn't label it, it becomes very, very hard to identify. Okay, so we understood aortic stenosis afterload. Let's look at aortic regurg. The thing is, aortic regurg, you have blood coming in from the atrium, and you have blood coming in back from the aorta, right? So the end diastolic volume is very increased, very, very increased. Now, understand this, because you're gonna see it in various things. Okay, there's so much blood that the heart is pumping in someone who has aortic regurg that you will see it visually. You will see it. Okay, their throat, their like arteries, their nails, their eyes, their eardrums, all of them are filled with blood. All of these are just pulsations. You see, this is called aortic man, right? All of these are pulsations. Okay, pinky sign. It means the nail beds, the arteries in the nail beds are pulsating. Okay, Mueller sign. You see the vessels in the back of the throat, they're pulsating. Okay, Corrigan's neck sign, Corrigan's pulse. You see, they're in the neck, and I will see the neck vessels, the carotids and stuff like that, pulsating. All why? Because you have end diastolic volume being very, very high. Does that make sense? Okay. Now I've written it here, right? Pulse pressure is systolic versus diastolic. Okay. You have to remember MAP, mean arterial pressure. Okay. You see, your heart stays, if you divide it, right, out of 60 seconds in a minute, it beats 72 times. If you do the math, 1 beat is equal to 0.8 seconds. The thing is, it's not contracting for 0.8 seconds, nor is it relaxing for 0.8 seconds, right? We notice that the heart contracts for 1/3 of the time, and the heart relaxes for 2/3 of the time. You understand? That's why the average is like this. How can you know the average if you don't know how much weight to give to these two, right?
Yeah.
So the heart contracts for 1/3 of the time and relaxes for 2/3 of the time. So MAP is based on that, right?
Okay.
So, when they say what's the most accurate measurement of blood pressure, it's MAP. It's not just systolic, it's not just diastolic. It's not 140/90. You have to, if you really want to diagnose someone with hypertension, what is the MAP pressure, and then compare it to like whatever the scale tells you. Okay.
Okay.
Now, just to sort of do the math, if someone has 120/80, what is their MAP? Or let's do 120/90. It'll be easier. 120/90. 120 divided by 3, that's 40, right? And 90 divided by 3 is 30. So 2 times 30 is 60. 60 plus 40 is 100. Make sense?
Right. Yeah.
Okay, good. So assume 100. Okay, I think I've written 93 because of it, because of 120/80. But assume 100. Okay, map of 100 is what is usually considered normal.
Got it.
Right. Okay, large pulse pressure. We understand this, and then you also understand. You see, I'll show you something. We understood EDPVR, right? This is the EDPVR. What is happening at this EDPVR?
Isn't it increase? Decrease.
So tell me the compliance. Is the compliance increased or decreased?
The compliance is increased.
Compliance is increased. That's the entire thing about, right? Compliance is increased. Why? Because you're volume overloading.
Yeah.
Right? You understand? Pressure overloading leads to concentric hypertrophy. Volume overloading leads to eccentric hypertrophy. You remember that?
Mm-hmm.
That's what we're seeing with the PV loop, right? You see over here, you see this is just fine. It's actually increasing. If you look at it, you see it's kind of increased, right? This means it's the compliance is being lost because there's pressure overload. Here, there's volume overload.
Okay. But it is going down, right? Like it looks.
No. You see, it's the compliance is increasing, right? But the graph is going down. Yeah, you're right.
Okay, good.
Yeah. Now you come here, right? Tell me about the contractility you're seeing.
The contractility is decreasing. Decreasing,
right? Now, even though this is mitral stenosis, you see what's happening is there's not enough blood coming in. There's not enough end diastolic volume, right? There's actually lower diastolic volume, right? Whatever you get, you're pushing it out, right? So there's no change in compliance or anything, but you see there might be slight changes in contractility, right? And this is us because we've learned about PV loops, right? But you see there's lower EDV leading to lower, the stroke volume, right? Stroke volume has decreased. Right? And you look at the left atrium pressure compared to all of these. The green line has been bottom of the barrel, but here, very, very high. Okay, that's why this squiggly line.
And then the green one is the right atrium.
Left atrium, yeah.
Oh, got it.
Yeah, you got it now? Left ventricle is down here, atrium is down here.
The mitral stenosis.
Yeah. Got it. Mitral regurg. Now, mitral regurg, you see, compliance is the same, but you see, again, massive amounts of fluid overload, right, in the ventricle. So end diastolic volume is very high. Contractility will slightly be, you can't even tell, right? You see, I would have to put it over here compared to this, right? Contractility is going to decrease, right? And then you see end systolic volume is kind of also like decreasing, right? So the stroke volume is massive. Stroke volume is massive, right? Yeah. EDV is also increased, and ESV is also decreased, okay? So a lot of people will get confused between aortic regurg and mitral regurg because they look the same. What I need you to look at, you see, this aortic regurg has perfectly fine end systolic volume, right? It's behind the curve. This thing is, so it's at the curve. This one is behind the curve. You understand? So notice that small change. It will help you understand or pick that correct option, okay? Because Amboss does this, I'll tell you. It'll take this exact graph. It'll give you A, B, C, D, and you have to pick which one's mitral regurg. Yes, so the end systolic volume is decreased. Right? And why is end systolic volume decreased? You see, due to decreased resistance and regurgitation into the left atrium, during systole, right? So you see, you're forcing the blood back into the atrium. So of course, the end systolic volume is going to decrease tremendously, but eventually all that blood will come back and it will cause EDV to be high.
Got it.
Yeah. All right. So next time you review this, I need you to, whatever reasoning I'm saying to you, right? You have to come up with those reasonings for yourself. Otherwise, you know, you're understanding it now, but you'll forget it later, right?
No, yeah, so, as soon as I'm done, I'm gonna go over it again.
Right. So you're gonna have to go over it because all these 4 or 5 pages, they're all very, very high yield, right? This will correlate to every pathology, everything, right? Just like I've done, you know, everything will be easy. HOCM, this, that, you know, everything will be easy after this. Okay. All right. So let's stop for tonight.